A very good evening to you who is watching UBC TV. Thank you so much for joining me on U Health Chat. My name is SOPHIA MATOVU. Now I'd like to read this for you. According to WHO, they say HIV, tuberculosis and malaria are diseases of poverty and marginalization with a heavy toll among a population that are chronically disadvantaged. Now, although remarkable progress has been made in reducing the overall burden on each of the diseases over the past decade, you'll find that certain groups, population groups, have persistently higher disease mortality and morbidity and lower access to life-saving interventions. Now, the existing inequities have been widely acknowledged as barriers to achieving global and national goals and targets in HIV, TB, and malaria programs. In studio, to shed more light on our discussion is Dr. Shaban Mugera, who is the Equity Plan Secretariat Coordinator at the Uganda AIDS Commission. Doctor, a very good evening to you.
Good evening, Madam Sophie, and Happy New Year.
Happy New Year to you. Welcome to the show.
Thank you.
Now, you know the words, some of these words, you know, we're used to more of the medical terms. Now, when you talk about what is health inequity, it might be a new thing to everybody else, and they're like, yeah, how come?
Thank you very much. First of all, I want to thank management of UBC, our national broadcaster, for accepting to host me and particularly the Uganda AIDS Commission to shed light on some of these issues, but most importantly, health basically. And health, as you know, is very important. It's only a health person that can produce and can serve his family and therefore at the end of the day the nation. So as you rightly introduced me, Shaban Mugera is my name. I'm the Equity Plan Secretariat Coordinator, but also a member of the Rapid Response Team for the Equity Plan Steering Committee at the Uganda AIDS Commission, meaning I work for the Uganda AIDS Commission. I am a public health specialist, and but also with a Master's in Business Administration from our prestigious Eastern and Southern Africa Management Institute. But on top of that, I'm a senior midwife made in our National Referral Hospital here in Blago. As I said, I work for the Uganda AIDS Commission, and we are an agency of government that with a mandate of overall coordination for the AIDS, HIV/AIDS response, multi-sector response. The question you have asked is very, very fundamental. Like you've given Ugandans that background. There are many health, inequities that exist in our service delivery arena for health as a country, but not only limited to Uganda. Many other countries suffer the same. So according to World Health Organization, health equity is the absence of avoidable, the key word here is avoidable, unfair or remediable differences among population subgroups, be they defined socially, economically, in all spheres of life. There shouldn't be any avoidable or remediable differences when it comes to access to health care services. Now, like you've quoted WHO, we find ourselves that in our quest to serve the population, which is a very important right for the Ugandans and other people who live within the boundaries of Uganda, we are supposed to offer free health care thanks to our government. Unlike many other governments around us and the world over, for us, health care here is we are so liberal. Our national health policy is such that anyone found within the boundaries of Uganda can access health care without even having to produce a national ID or health insurance card. So that's how liberal we are. And that means we serve people not necessarily Ugandans, but whoever finds themselves, whether you are from South Sudan, DRC, Congo, you're Rwandese, which is different from some of those neighbors of ours. So in our programming, as the Uganda Commission together with Minister of Health, because the program I'm here for coordinates 3 disease programs, that is HIV, TB, and malaria. So the way we program to offer services, we inadvertently find that there are some population subgroups that are not getting a fair share of. We tend to assume that one size fits all, and that has been so for quite some time, until some time back in 2017, with the support from Global Fund. I want to assume that Ugandans know that one of our sources of funding for health care, especially when it comes to delivery of HIV, TB, and malaria services, the Global Fund.
Global Fund too.
We are one of the recipient countries to the Global Fund. So we realized, following a baseline assessment that was conducted in 2017, that yes, we are using a one-size-fits-all in our programming. For example, I'll give you an example. Global Fund gives us money to procure mosquito nets, and WHO recommended that universal coverage simply equals every 2 human beings having a mosquito net. So we, at one time when we started that program, Ministry of Health, we bought 23 million nets to be given to about 42 million Ugandans. That means if you divided, every 2 Ugandans would do, and that's what we call universal coverage. So forgetting that there are some population subgroups, even if you gave them a mosquito net and you guided them on how to use it, because of some structural and social, economic, and housing issues, they cannot benefit so much from a net. An example, our brothers and sisters who live in Karamoja, by way of their dwelling houses called manyatas, they are this high, and they cannot afford even the luxury of hanging up that mosquito net. But aside of that, the young, energetic youth stay out in the night on guard for their herds of cattle, sheep, and goats, for fear of rustlers. Now, you go out and say, yes, one size fits all. We have distributed mosquito nets, including our brothers and sisters who live in Karamoja and reside there. They are not going to be able to use these mosquitoes, and therefore, by their way of life, exposes those young people to being bitten by mosquitoes, and that's the time, the peak hours for feeding of mosquitoes. What about our colleagues who live in refugee settings, in prison settings, with hardly any space to put their heads? What about the children under 5s and the pregnant women whose immunity is usually lower? But also Ugandans, we have done a good job. We have produced many children. You might give a mosquito net, and a mother has very young children, one after another, a difference of 1 year in between, and she may not be able to put all those under mosquito net. So we realize after that baseline that there are certain people, especially we call them priority and vulnerable populations, or key populations if you like, who may not necessarily be benefiting from the services as we program to offer them. Others, because of the laws, the structural barriers, there are structural barriers. Like we have an example, the HIV Prevention and Control Act of 2014 has some clauses that criminalize HIV transmission, and I'm glad government realized that something needs to be done in this. So there are certain barriers hidden, and unless you think critically, because for example, the malaria control program never used to think that there are vulnerable people in that program who can actually, because once you procure mosquito nets, you put the medicines in the health facilities, and you give them even to the village health teams who do community case management, house to hold kind of, they check every child with a fever, they advise you to go to a health facility. Then you've done it all. For other places, you do indoor residual spraying.
And then you believe you're sorted.
But there are, for example, Muzee's granddaughters who are involved in sex work. It's a very serious business in Uganda, just like other countries. They stay out most of the night. Now they have just woken up to go to the streets to start work. Now such a person, during the days you plan to offer these services, for example, HIV screening, you know, testing them for malaria, distribution of mosquito nets, they are not with you. They are asleep. So you have to program in such a way that you tailor your services
to cater for them
to
well.
Their lifestyle, and also to cater for them. That's where why we are saying, let us now tweak our programs slightly. And that's why Global Fund and government of Uganda entered some kind of agreement and said, hey, we've supported you for so long, but in our view, and it's also in your reports, not everyone is benefiting equally. And yet, you know, these resources were set aside for low-income countries so that we can uplift you in terms of your standards of healthcare, so that you can be empowered enough to offer healthcare to everybody. You avoid those inequities. So now countries were called upon to reprogram. So for us, based on the findings of that baseline assessment, which was conducted in 2017, we had to put in place a response plan. How then we address some of these barriers? These barriers like gender-based violence, it can be a barrier to access to HIV services, even malaria.
Before we get into the barriers, I'm just curious to find out, because ideally, yes, under the Global Fund, most of these programs are each supported on their own. Or how should I say, the diseases. Yeah, you'll find that there is a plan, or there is a fund for malaria, there is a fund for TB, there is a fund for HIV/AIDS. And when you talk about Uganda AIDS Commission, we know that we are talking about HIV/AIDS. How did they choose to get and put them under one umbrella? And what is the connection between the three diseases?
Thank you very much, Madam Sophie. It is actually a very, very interesting story, and it's happening for the first time in our country, that I can come to a national broadcast and talk about the three diseases. Unlike in the past where we had this verticalism and acting in silos. HIV has a strategic plan, malaria has a strategic plan, and TB has a strategic plan, and everybody for themselves and God for everyone. So gone are those days. So what happened is that Global Fund was created way back in 2002 to support three diseases, and resources are pulled together whenever there is replenishment. Rich countries contribute, but also poor countries like Uganda, we also contribute to that basket to be shared out eventually. Supports three diseases. That's why it is a global fund to fight HIV, TB, and malaria. So now it was realized that if low-income countries were left on their own, they may not manage these three monsters. Particularly HIV was the driving force when we were losing many people there, and so they created the fund. Now, because the fund supports three diseases, when the survey was commissioned to assess whether people are benefiting from these services equitably, inevitably it brought out aspects that you speak to the interconnection and interrelatedness between HIV, TB, and malaria. I'll give you an example. We know that almost half of patients, clients, we don't want to call them patients anymore because of our modern care, improved care. People living with HIV and AIDS, about 40% of them may suffer TB as a comorbidity. Comorbidity simply means one has another illness on top of what they already have. And the biggest killer of HIV patients is actually TB. and the other way around. If you have TB, then you're more vulnerable to acquiring HIV as well, because you have some insult on your immunity. Equally, a person living with HIV, because of the insult on their immunity, they have higher chances of catching a malaria episode. Between you and me, if we're healthy and we've lived in Uganda, I was born in Uganda in a malaria endemic district, and therefore I was bitten by mosquitoes since I was a child. So you have some, you have immunity over time.
Yes, true.
But now, should there be a challenge on that immunity, and I catch, for example, TB or HIV, it means my immunity is going to reduce. And ordinarily, if I didn't have HIV, like when I used to catch malaria, I would even test, and they say those were days when they would tell you pluses. You have 2 pluses. I would just go and play football, and the malaria, the body fights the malaria. But for a person who has an insult on their health, on their immunity, they will not be able to do that. Even 1 plus will bring that person down. They will definitely fall ill. So that's how interconnected these are. But by way of planning, we said, since the survey has unearthed barriers, we'll be talking about barriers shortly, to HIV, TB, and malaria service access, why don't we now put up a response plan, a joint response plan? After all, we are getting money from the same basket, and when it comes to countries competing or writing to the Global Fund to ask for that money, we see it basically in the same room, and we are the same people, but we are targeting the same Ugandan. Why should we act in silos? But that after the realization, after we agreed and had teased out the more vulnerable population subgroups per disease area. So we agreed and said, oh, these are the vulnerable populations as far as TB is concerned. These are the vulnerable populations as far as the HIV is concerned, and these are the ones for malaria, like the examples I gave for malaria. For TB, I'll be giving some people who live in in congested places like refugee settings, in prison settings, and then for HIV, I've given you an example of the sex workers, the injecting drug users, those hidden populations. So we said, why don't we now put up a plan to respond to these, to the vulnerabilities these people face? They face double jeopardy. When it comes to programming for services, we have been using a one-size-fits-all, and we don't seem to satisfy everybody. But now they are already vulnerable compared to the general population. Why don't we single them out and say, so we put in place a response plan to address barriers to access to services for the vulnerable population per disease program. And this is a combined, it's a tripartite, it's a kind of a tripod. It had the plan, the response plan, elaborates interventions for addressing barriers to the 3 diseases, and we call it a national plan for addressing barriers of access to basically eliminating them. We want to eliminate barriers to access to TB, HIV, and malaria services, and we call it an equity plan. So and I've already defined equity.
Do you have, like, I would say certain times, if it's starting for the first time, you might have specific regions where, like, this is where this situation or scenario is a little bit on the high, and you have reasons and cause to say, we are starting with this region, or it's going to cut across given that it's a national plan?
Well, thank you very much. We are even discussing at the tail end of implementation of this plan. The baseline was done in 2017. We developed the plan in 2019 and launched it on December. It was launched on International Human Rights Day, which is commemorated on December 10th every year. So we launched it, and since then we've been implementing it for the last 4 years. So it spans up to 2024.
How popular is the plan?
Actually, one of the reasons we booked to be hosted, and you kindly accepted to be hosted on a national broadcast.
So it's popular?
Is to continue popularizing it. We've not had a lot of occasions, opportunities to disseminate it widely to the wider population. And by us appearing, by me appearing on a national broadcaster,
you're popularizing
I'm
the plan.
popularizing the plan. But it's never too late. I'm popularizing it in its 4th year, and we are going to implement the final year of the plan. But we are best example on the African continent. We were the very first country to have come up with such a plan, a framework called an equity plan for addressing barriers to access. Many countries are lagging behind, and we are. So much as we are at the tail end of it, we have done our best. We've visited almost all regions. We've had a lot of occasion to talk about the equity plan. We have commemorated International Human Rights Day since it was launched. We've not missed any. The recent one was held on December 12th last year in 2023. And whenever we have opportunity to meet, and I want to think the media has been doing a good job. They have been covering our deliberations about this. It has it's a plan that was crafted in such a way that it has 10 result areas. We conducted a mid-term review for it, and we provided for challenges brought on board by COVID. Initially it had 9 result areas, but now we provided a result area for COVID. For COVID. Okay. And the very first, which is the most fundamental key result area, number 1, is ensuring that we fight stigma to zero. There is zero stigma and discrimination to people living with HIV and AIDS, but also people living with TB, as well as the survivors of TB. We call them survivors of TB disease. But also ensuring that there is a lot of, we address stigma meted against, for example, the clients in the area of malaria service delivery. For you, maybe we gave you mosquito nets. How come you've come down with malaria? Sometimes health workers use foul language. How did you catch malaria after all the government efforts for fighting malaria? We've given you nets. We have given these medicines being distributed at community level. So the aim of the plan is to look at all those barriers, be they structure, if to do with the laws. We are at loggerheads with the lawmakers, not necessarily loggerheads, but ours is to do advocacy and lobbying, and we work a lot with the civil society to say, hey, wake up our legislators. It's not that you must legislate against each and every disease. Sometimes the laws that we put in place may act as a deterrent to service delivery. True. For example, these key populations have been legislated against for so much, the recent being the Anti-Homosexuality Act. And for us, from the public health point of view, we thought, yes, this is a very progressive law. We want to protect our morals as Ugandans. We are a highly religious country. But we have a challenge. As public health specialists, ours is to ensure, and as World Health Organization defined health equity, we must ensure that we don't leave anyone behind, regardless of your religious affiliation, political affiliation, your sexual orientation. It's not our business for you to say, I'm a lesbian, and therefore it's up to you to see whether you are going to give me service. Even if you introduce yourself as a lesbian, you introduce yourself as a gay man, openly gay. My job is to for as long as you have an illness episode, because life is fundamental, health is a fundamental human right. I'm supposed to offer you health care. I've always given this example. My father is dead 10 years now, but if he were to come back to life today, and then for one reason or another, a soldier, any gun-wielding Ugandan and is trigger happy, shoots them, and then he is subjected to kind of mob justice. They want to lynch that person. And I'm the only doctor in that vicinity. My oath is I must save life first. My father, I forget about my dad who is dead. Suppose he has been cut several times and is bleeding profusely, and it can lead to his death. I'm supposed to first attend to this bleeding person, ensure that I save their life, then I hand them over to police for prosecution. Then I come and now attend the dead body of my father and arrange for burial. That's how funny it is. So our hands are tied as the health professionals and the public health specialists. For us, from the public health point of view, we are saying, yes, we have good laws in place. HIV Prevention and Control Act is good. Somebody deliberately transmitting HIV to another is not a good thing. That person is like a murderer. But for as long as it's going to deter people from accessing HIV prevention services, then
it becomes a barrier.
It becomes a barrier.
Yes,
and therefore
yes.
we propose that probably some amendment has to be done using those equity lenses, because ours is to ensure people, and we have set goals. We have for HIV, we have a presidential fast track initiative. We have a TB elimination strategy. We have a strategy to end TB by 2030. Presidential fast track initiative to end HIV as a public health threat by 2030. Malaria elimination. So in order for us, if we are to hit those targets, then you must make sure we are moving along with with the entire population in this diversity. Otherwise, if you say sex workers are going to remain behind, those gay people are going to remain behind. And the worst thing is that for HIV, for example, they suffer disproportionate HIV prevalence rates compared to the general population. For sex workers, in the range of 31 to 35. In the general population in Uganda, out of every 100 Ugandans, about 5 have HIV. But for them, if you went and sampled out a population of sex workers, for example, in Kalangala, you find that about 30 out of every 100 have HIV. So, and these serve many people. There are times of scarcity on the lake shores there, when men line up to be served by one person, and suppose this person has HIV, it means she's going to infect
and infect most of them.
So for us, from a public health point of view, I'm not going to bother whether they are sex workers. I have to reach out to them with my services, even if it means missing my sleep, and I go. We call them moonlight services. Surprisingly, as health workers, we don't sleep. I told you I'm a senior midwife. For me, most of the mothers deliver at night, and that's what I enjoy doing when I was actively in practice. Now, for HIV services in particular, for such population subgroups, you must make sure you do things differently. You think out of the box. You say, let us forget about the normal programming. We tweak our programming a little and ensure that we tailor services to the lifestyle of these people. They are now awake and busy waiting for customers. That's when we reach out to them. So if police finds me now at night, I'm moving with condoms. I'm moving with the test kits. That's what our health workers do, unfortunately, or fortunately, to safeguard the lives of these Ugandans. Because if you don't arm them with those protective equipment, then they are going to infect these unsuspecting Ugandans. And sex work has been there for eternity. You cannot wish it away. So the best is for us to make sure, and the developed countries even do it much better. They gazette such places where such work happens, for example, sex work, and it's a booming industry, but they protect those people so much. They screen them for sexually transmitted infections. So, and you who is going to purchase those services, you know while knowing, and they will give you protective equipment like condoms, because a condom is one prevention intervention that has saved many lives and is scientifically proven to be efficacious. So, but in Uganda, we adopted a combination prevention approach. No single HIV prevention intervention is 100% protective. It ranges from HIV testing. You have to start by knowing your HIV status. Then from there, if you're HIV negative, we give you risk reduction counseling. To remain the same, go and thank your partner, stick to your partner. And we have not forgotten our ABC strategy, which brought us far. In the 1990s there, our prevalence reached 18%. But because of the political will, especially led by His Excellency the President, we were able to bring down the prevalence of HIV to where we are now at 5.2, which is a good thing. And the population listened. So, and we agreed we are going to now use a combination prevention approach. if you cannot abstain. For the young people, we emphasize abstinence. Wait until the age of marriage, and we want to keep them in schools. That's why there are programs like UPE, USE, and others. The longer you keep a girl child in school, the more chances are that she's not going to be tempted to either conceive. You know, teenage pregnancies are also high. Many things, they face a lot of obstacles along the life cycle. So the combination prevention approach is such that we preach to people: abstain, be faithful if you are in a marital relationship, and where things if you think you cannot abstain, then use a condom. If you are going to move out with a non-regular sexual partner. And then we have added on many things. Circumcision is beneficial to the men, offers about 60% protection to a man, but not to a woman. So, and that's why His Excellency guided us. When we brought on board circumcision, the message was misleading a little bit. People used to think when a man gets circumcised, they become armored. They become armored like the presidential vehicle that he moves in. And when he corrected us, we said, no, people must learn that we are using a cocktail of interventions. Even if you're circumcised and you are going to move out with a non-regular person, please remember to use the what? A condom. We have added on other products like PrEP for people who find themselves at substantial risk of acquiring HIV, especially the sex workers and other subcategories of people. They are perpetually, imagine a sex worker, their core business is to go on the street and wait for customers. And for them, they call it good business. Like now, we have many conferences going on. We expect many visitors. For them, they are looking at business prospects.
Yes.
So when you interact with them, they tell you, on a good day, I can serve anywhere between 10 to 20 men. Can you imagine serving? For them, that's a good day. Now, but such a person, if you don't offer them, and some clients may not adhere to the use of the guidance of use of a condom, they lure these young granddaughters and sons of Uganda. When they get in those private places, they abscond from using a condom. So we have other interventions we deploy. We deploy ARVs, and that program is called PrEP, the drugs for pre-exposure prophylaxis. So we agreed that we are going to use a combination prevention approach to safeguard our population. And that's why the equity plan is more or less speaks to those vulnerable people. For malaria, children under 5, pregnant women, people living in refugee settings, prisoners, and TB congested places, the slum dwellers and others. And then we say, hey, we must do things differently. That's why we use a human rights now approach. This is not to say that we work against the laws of Uganda. For example, the Anti-Homosexuality Act, for us, we are saying even the gay people should come and access services. We shouldn't deny them. And that's what the equity plan tells us. We don't want to leave anyone behind. That's the hallmark. But we want the law to be implemented at the same time. Should somebody be found to be ultra-vires with the law, they are in conflict with the for example, if somebody involving themselves in aggravated rape or defilement, the law should take its course. If somebody is found recruiting our young people in schools and you are indoctrinating them into these bad vices of homosexuality, why shouldn't the law catch up with you? But Parliament was good enough. They relaxed the law and said, let people be given a second chance, be spoken to. And it's an issue that cannot only be handled by one person. The entire, right from the family, we have to address the issue of homosexuality at community level, the religious leaders and cultural leaders, because these children come from within our families. So we want the Parliament relaxed it and said people should be given a second chance, and they should be spoken to abandon, because there are many alternatives. What mainly drives them into such practices is the economic gains. We realize, and now government has come up with many programs, skilling programs for those who are not in schools, who are not employed, but also the parish development model and many others which I cannot name. I'm basically a public health specialist. I don't speak a lot of
about the areas. Now, Doctor, I'd like to ask you, can you record or say any success regarding this plan since it was started, the national plan?
Oh, thank you very much. Very much appreciated, and indeed being the first of its kind in this country, and the fact that we are the guinea pig country on the African continent, we've scored a lot. One, we are one country that has commemorated International Human Rights Day every year since the launch of this plan. And what we do, we bring together many stakeholders, members of the judiciary, parliamentarians, the media, the affected communities for malaria, TB, and HIV. And now we highlight the contemporary interventions that are available for prevention of TB, HIV, and malaria. For malaria, we're now talking about smart homes. A smart home is a home that is not overgrown with the bush around, that has no stagnant water around, where people are using the nets as given to them by the Ministry of Health, as government of Uganda, procured using Global Fund money, and that they listen to the VHTs. Anybody who develops a fever, a child, be it a pregnant woman, they take them for malaria test, and they give them medicines. Because malaria by far is the biggest killer of Ugandans, especially children and pregnant women, and it leads to pregnancy wastages. So these are things that are preventable. So we've been able to drum this, and we have been able to highlight the most vulnerable population. We conducted an intervention called a matchbox assessment. Because as I said, when the assessment was done, the baseline, it brought light these population segments or subgroups that are not benefiting equally. And the malaria program and TB programs, we took long to onboard them. They could not believe. But when this malaria matchbox assessment was done, it's done scientifically, it opened their eyes. It said, oh, so the way we've been programming is not the best way. Now they have interventions for refugees. They have special interventions for people in prison settings. They have special interventions for young people under 5, the pregnant women. That's why today, every pregnant woman, even if one is to conceive every year, when they go for antenatal, they come back with a mosquito net because of the vulnerability that they have compared to the general a woman in the general population who is not pregnant. So that's, we've scored a lot by highlighting this in all the fora that we've had. We've also had engagements with the, for example, RDCs to create an enabling environment for continuity of services. We have also drummed for the stigma. We've come up with an anti-stigma policy, stigma and discrimination policy at the Ugandese Commission. We've even translated it into Braille and sign language for people living with different abilities. So we've done quite a lot. Now every year the TB program commemorates an event. We conduct a TB marathon to popularize the fact that TB is a killer disease, but it's curable after all. It's even curable. Why should people continue dying of TB when it's curable? There is medicine for it. Some of these diseases, not so much was being talked about them before these interventions came in place, this framework. We now also conducted a TB gender study to try and understand the way we are programming for TB. Are we addressing everybody? And a kind of costing to see the implications. If a Ugandan went out to look for services for TB, how easy is it for them to access those services? So the costing study revealed that actually there are people who are suffering catastrophic expenditure. When you spend more than 24% of your income as a household, then you are in levels. You can be impoverished because of health care expenditure. Government, yes, is offering TB services for free, but there are hidden costs of transport to the places where you're going to get TB services. And they also conducted a community kind of screening called the TB Cast, where we found many cases of TB that we were missing before. Because we are supposed to meet a certain number. We are one of the high burden TB, 30 high burden TB countries on planet Earth.
Uganda.
And so, Uganda. And so we were missing many people infected with TB. But the intervention of, screening everybody house to house, we were able to identify how I wish we could get more resources to be doing this quite regularly. As I told you, for malaria, the matchbox assessment revealed many population subgroups, where they are and how, because of their behavior. For HIV, we have always known that there are key populations. The key populations are those who have who are at a higher risk of acquiring HIV by way of their lifestyle, and we have named them according to our national HIV strategic plan, which is already signed up to by His Excellency. HIV control was placed in the highest office in the land. That's the President's office, and is the lead champion in the fight against. And good enough, our President has been lauded worldwide for being the most, astute and head of state when it comes to prioritizing the fight against HIV and AIDS. So many people have learned, many presidents, learned from him. So that alone, we highlighted who are the key populations in the HIV arena. We know I named the sex workers, people who inject drugs, the men who have sex with men, those transgender populations. I was born a man, but I feel I'm in the wrong body, so I want to live like a what? A woman. Like a woman. And those are things that people have copied because of globalization and other things, and we can't hide our heads in the sand and say in Uganda those things are not there, because we are seeing young people who are behaving as such. And so our job is to say, hey, these are even more vulnerable to acquiring HIV, TB, and malaria. So we must do things differently to make sure we help them. We have been able to, for example, when the Act was passed in Parliament, we thought it was going to impact. There were unexpected consequences of the Anti-Homosexuality Act. We went out and spoke to the law enforcement agencies. The Director General, Minister of Health, issued a circular to the extent that it was basically highlighting a provision of services to all Ugandans in their diversity without discrimination on either by on religious grounds, on political grounds, and maybe sexual orientation. So that circular has helped us, because the law, the way it was crafted initially, it was being interpreted differently by different people. And for example, even a health worker would be accused for abetting homosexuality if they served the homosexual and they didn't report that person to police. But good enough, Parliament went back and reviewed the law and said, no, access to services is for everyone. We did not intend.
Human rights.
The aim was to curb promotion and recruitment, so that the few that are there, we speak to them, they change, and we get back to our values as a country. We are a religious country, we have our morals, not for the money. We should not just accept anything because of anybody's money. And good enough, Global Fund did not target their funding to that law. For them, they said, much as Uganda has this law, we shall continue funding you. And we are using Global Fund money, even as we talk today. We use the Global Fund money to come up with that framework, the Equity Plan framework, and we are using Global Fund money to sensitize the population about the dangers of TB, HIV, and malaria. Our targets we have set, and the need for us to move along with everybody. We should not discriminate.
My final question to you, which you need to give me a response to in a few minutes, is this program, after this, is this because if you say we are the first to be experimented on this kind of program, we are the guinea pigs, do we see this being carried across into the other African countries basing on the story of our success, Uganda as a country?
Thank you very much. As I speak, many other countries have already come up with a plan. They came up with a plan much later Theirs are still young. Some have implemented for 1 year, others 2 years. South Africa, DRC, Congo here, South Sudan here, they have a similar plan. But ours is more mature and advanced, and our program is advanced, and they are learning a lot from us. How has Uganda, like Uganda has always been a learning destination to many of these countries. We come up with good policies, strategies. They just come and Xerox and go and implement and get results. So this much as we are the guinea pigs, we were just the pioneer country on the African continent to have come up with this. You know, the Global Fund basket was intended for low income countries, and we are among the like 100 and something countries. So for us, following that assessment, we said we must lead by example. And for us, we are a very democratic country. We observe people's human rights, and that's why our human rights credentials are a little higher compared to other countries, in that we have ratified many international and regional, you know, instruments to the effect that we shall uphold people's human rights. So that's why even our health policy is the most liberal on planet Earth. Can you imagine a Congolese just coming here and they consume our health care without paying even a coin? That's why our budget has never been enough. We try to buy drugs, but because they are consumed by people who are originally we had not budgeted for. Before you know, the budget is exhausted. And you cannot have inelastic resources. We have to have. But I'm glad we are now coming up with a national health insurance scheme. The minister the other day was giving us updates, and I want to call on Ugandans to follow. When you are told to contribute for national health insurance, please do, because you pull the risks together. For example, I may pay. I last had malaria in 2005. It almost killed me. But since then, my wife, when she lived, I lost her 2 years ago. When she lived, she would not allow me to sleep without a mosquito net. And it is imprinted in my brain that a mosquito net is key. Whether I go up country for government work, I must sleep under. So if I contributed and I'm pulling the risk of suffering a malaria episode, in a year, a Ugandan suffers about 4 episodes, four attacks of malaria, if you are not protected enough. Now, for me, for those years, I've not had any bout of malaria. Meaning, if I paid a premium to guard my life against malaria, then I will have paid for that vulnerable Ugandan, maybe that pregnant woman, that son of ours in Karamoja who sleeps outside the whole night on guard because he's going to suffer. That's why the malaria now is hitting Ugandans in epidemic forms. We have regions where it has peaked, Karamoja being one of them. Busoga is another. You heard the other day in Namutumba, people were dying and they thought maybe a strange disease had hit the people, only to investigate. Malaria. Before they had malaria, they were dying of malaria. You know, they say a disease is drinking people's blood and they are dying when they are pepper white. Malaria destroys blood, and then so then in West Nile, in Lango sub-region, districts of Aleptong, where Amolata. So now with Ministry of Health, we have worked with them in such a way that now we have changed the mode of management of this malaria. Now we are using the incident management. The way we manage the COVID-19 is the same way we are advocating on a daily basis. Every district must be on the alert. Once you see the numbers of diagnoses of people with malaria, because now we have the diagnosis of malaria can be made easily. Courtesy of this, I mean, these rapid diagnostic kits, and we are using a results-based financing kind of approach. We urge health workers not to treat. In our days when I trained, every fever was treated as malaria when I was a young medical officer. But now you can't treat somebody with anti-malarials unless you have confirmed that actually they have malaria, because it used to be very difficult to diagnose malaria. Okay, then, so that is what we are doing, and it's a good thing always to lead and other countries follow.
That's fantastic.
I don't care whether they lag behind, for as long as Ugandans are safe from TB, HIV and malaria, and for as long as we can hit our target of ending those 3 diseases by 2030, I'll be the happiest.
Thank you
I'm going
so
to retire
much.
a happy man.
Thank you so much, Dr. Shaban Bugera, for your time and
you.
for that useful information. We do hope maybe next time we'll get an opportunity to host you again, and then you can be able to delve further into this topic or another topic of discussion.
Thank you so
Well,
much.
that is all we had time for you tonight. It's just about like 5 minutes to the top of the hour, and Rod and Gonzi will be coming your way with the 10 o'clock news. It's good night from me and from Dr. in studio.
Bye and Happy New Year, Ugandans.
UBC, inspiring Uganda.